HIV in old age tend to have multimorbidity. If you look at literature now, there's quite a number of papers that are coming through demonstrating that multimorbidity is a significant challenge among people living with HIV in their old age. We have learned a lot of lessons over the decades that we have looked after people living with HIV. We have rolled out HIV programs across the globe for many years now. And I'm sure there are many lessons from the HIV programs that we can use in terms of integrating with non-communicable diseases and also looking after people as they age with HIV. The next slide there, I don't need to talk much into it. It just demonstrates to you that, yeah, the proportion of people living with HIV in our treatment programs above the age of 50 is on the increase. I always say to people, if you're a pediatric HIV specialist, yeah, the cohort is shrinking. At some point, we made so much noise about adolescents. The cohort is shrinking. Adults, the cohort is shrinking. Why? Everybody is growing old, and including the people in this room, we are all growing old. So we need to make sure that we are ready to look after an aging population. So in terms of definition, next slide, what are HIV services? Most of us are into HIV programming. Most of us are in HIV clinics. What exactly do we call HIV services? Because if we are talking about integrating HIV services and geriatric services, it means we need to know what those HIV services are. We need to know what geriatric services are. So I put it to you that HIV service delivery really includes a comprehensive package where we do HIV testing, we do HIV prevention, and we also do treatment and care for those living with HIV. So HIV services is the prevention aspect, the testing aspect, loneliness. I can't overemphasize that. And then something that we really talk about when you talk about the elderly, the whole issue around stigma. Imagine being a 73-year-old sitting in the OI clinic waiting for your chance to get ARVs. Besides you is a 16-year-old, besides you is a 22-year-old, and then the nurse comes and says they want to do health education and they want to teach you condom use, and you have brought your daughter-in-law to the clinic. Imagine all that. So all these are issues that the elderly have to battle with. And then comorbid conditions, you've spoken about them, diabetes, hypertension, cancer, and all these issues. So when it comes to integration of geriatric and HIV services, as healthcare workers, we must ask ourselves, when these recipients of care come to us, are we offering them, are we addressing all those issues, or we are just concerned about their HIV status? Next slide. So, am I doing well in terms of time? 5 more minutes. The next slide, just some thoughts in terms of what must we offer our elderly, previous slide. What must we offer our elderly patients? Number one, let's offer some are living with undiagnosed HIV. Let's offer them HIV testing. If they are negative, let's offer them HIV prevention strategies. I spoke to you earlier on that it is possible to get HIV later in life. Elderly people are getting newly infected with HIV. Let's offer HIV prevention. So when we talk PrEP, we talk condom use, whatever we are talking in terms of HIV prevention, let's also remember the elderly. Sorry, let's go back to the previous slide. Let's offer screening, let's offer early initiation of ART, because these elderly individuals, their immune system is aging as well. They tend to present with advanced HIV disease. So we must quickly offer them ART. Let's offer screening and management of comorbid conditions. I think in 2023, it's unfair, it's unethical, it's borderline on being criminal to run an OI clinic without a BP machine, without ability to test for blood sugar, and yet you say you are offering comprehensive care. Let's screen for common cancers, cervical cancer, common cancers within our regions, and let's also offer mental health issues. And then finally, we can go to the next slide. They really wanted to move to the next slide. So I'll just conclude with this slide. So this is results from our clinic at Newlands Clinic. We have recently introduced geriatric services where everybody above the age of 65 goes through a very comprehensive assessment. What we have realized is that there's significant burden of hypertension. Approximately, I think 80% are hypertensive, 20% are diabetic. Frailty is a major issue. Chronic kidney disease is a major issue. Mental health is a major issue. Vitamin B12 deficiency is a major issue. So we need to respond to all that. Final slide. Thank you. All right, I'll end there. Thank you very much.
He does deserve a round of applause. Very sobering facts from really just a clinical point and just looking at a patient. We are all talking about patient-centered, human-centered. It's one person with all these comorbidities. And if we're saying we're providing comprehensive care, are we really? And the reality of geriatric care is beyond just HIV, is a reality that we are all now facing as life expectancy is increasing and we're getting more older people. So how do we then integrate the integrated service delivery models? I don't think we have Barbara online, do we? Maybe I should hand over to Dr. Trust. Welcome. And maybe you can give us some reflections before we take hands from the floor. Is that okay?
Yeah. Okay. Thank you very much. Slightly late. I think the traffic was something else. I was actually coming from Parinyato Hospital, where I work. And I can tell you, the 3 calls I've just had, it's just been elderly patients with HIV that we've been seeing on the ward rounds. And one wonders, you come to such a meeting, you're looking for pearls of knowledge of what do you do? because literally half your patients who you see on a post-intake round have HIV as a comorbid condition. And I was really looking forward to Barbara's talk. I hope that she can come through on the biology of aging. But if not, then I think we could take questions, right?
Thanks, Dr. Trust. Can we have then questions from the floor? Very sobering thoughts on the whole cascade of HIV, care, aging, just from awareness, prevention messages, finding cases, and then just really treating an individual as a human being that has many other issues beyond HIV. Questions? Are we all just letting it sink in? Yes, Dr. Njeri? Sorry, just wait for the mic, please. We can't hear you.
Thank you very much. My name is Dr. Jerry Kamere. I'm with the Oram Institute in South Africa. And so we're also implementing a huge care and treatment program in one of the provinces. And so it's interesting to just hear other inputs on the aging population. I think when we started looking for the positives, it never occurred to anyone that they would age. And now it's that sobering truth that they're actually aging. So what happens? And I think that integrated service delivery model will almost be looking for, like, how is it going to work practically? Like that 75-year-old with all those comorbidities. We don't have, like a unicorn healthcare worker who'd be able to do everything. So when we say integrated service delivery, it's maybe they move from one room to the next room to the next room. Now we're adding cataracts, and I'm an ophthalmologist as well, so that's close to my heart. And so how then do we integrate all these issues that our aging population has? And I think it's something that we need to keep talking about because it's a bit new. No one had really thought about them, and also just how they're coping, the mental health issues, how they're coping with this diagnosis. With different phases of life, new issues come. Now they're going into pension. Maybe their pension money is not enough, so taking their medication could be the last thing on their mind. But thank you very much for the presentation. Thanks.
Dexter Sanjari, and I think I would like both Dr. Kefas and Helen to respond to this because it's really about the how at a clinical level and also in terms of modeling the integrated service delivery.
So just first reflection, and Clifford's fantastic presentation, I think, because you're doing this and you're doing this at a specialist centre in the capital. Most of those 80-year-olds are going to a rural clinic where there's 2 or 3 nurses who are expected to do everything, including ANC, etc., etc. So I think we have to be pragmatic, and I think also it's about capacity building and strengthening the knowledge so that I'm going to stick on hypertension and diabetes. I know there's a huge number of other comorbidities, but if we can strengthen how they are managed and identified earlier and managed better, we can also avoid some of the kind of longer term complications. But I think your point is, how much can we expect a nurse at a primary care level to do? And I think that's about looking at how do we simplify the management of some of these conditions, giving very clear, ideally 1-page, this is what you can do up to this point, and then the ability to refer. But I think realistically, most of this is probably going to be managed in a primary care setting. I think we need to start thinking out of the box. But I think there's things that we can do to enable task sharing and nurses to be able to manage some of these common comorbidities. And I think we can definitely do that better to enable that task sharing, because most of these elderly people are not going to get to a specialized service, I'd imagine. Yeah.
Thank you. Thank you for your comments. I think you're right. It's going to be a multidisciplinary team approach. But then in our facilities, we are not going to have the endocrinologist. We're not going to have the ophthalmologist. But what's important is that we invest in the primary healthcare provider and capacitate them with the necessary tools that are required to screen these common conditions. So a nurse in the rural health setting can have a Snellen's chart just for visual acute assessment. And then they must know that if the result is like this, I refer to where. A nurse at a primary care facility must have a glucometer, must have a BP machine, must have standard operating procedures and clear guidelines. When do I start antihypertensives? When do I start antidiabetics? When do I refer the patient to the next level? Must have a screening for mental health. When do I refer? So all I'm just saying is let's invest in managing these comorbidities. Let's simplify, let's provide the necessary tools so that primary healthcare providers can be capacitated and have clear referral guidelines. Thank you.
Thanks, Dr. Cleophas. I really like that. I mean, you are reminding me that there's also the issue of polypharmacy. So there needs to be an awareness when they see symptoms, people coming to the clinics and think of the drug-drug interactions from the myriad of drugs that a patient would be taking. But we've got more hands. Maka, you had a hand, and then a gentleman here. Will take those two and then have a response from the panel. Thank you.
Thank you very much for the very insightful conversation. My name is Makaita Gombe, also from the Oram Institute. And my question is, now that we've had a chance to see into the future, how are we going to take a lot of this and have preventive measures for the current adolescents and the current young adults to ensure that for some of them that can be prevented, how do we prevent maybe 5 of the 10 that you had on the list?
Thanks, Maka. The gentleman at the front, and then a response.
All right, thank you very much. I think this has been quite a very interesting conversation. We've had this conversation before at a more broader level, and I think I want to agree with most of the feedback from Helen, and I didn't get your name.
Cleophas?
Yes, Cleophas. So I just want to highlight some of the experiences we've had, because we've had an opportunity to pilot integrated something like this in Nigeria. So I think from tax shifting is very important, and policy is also very important. We need to have a simplify. In Nigeria, we have a simplify algorithm, especially for hypertension. So even the nurses, community health extension worker are able to identify and initiate client on treatment. So when they call the screen, so we're already seeing most of these. And from the client's angle, there is an increased enthusiasm towards managing their non-HIV condition. So it also has helped to improve retention on treatment. So I think once we start with most of these, beyond having this discussion at this forum, having the willpower to follow through, and most of these doesn't need too much of financial commitment. So you just need us to be more deliberate about how we approach healthcare, especially at the PSC. So thank you very much.
Thank you very much, sir. I'm sorry I didn't call you by name. It's just because the other two I knew the name.
Paul too.
Dr. Paul.
Yes.
Thank you very much. I think because we've got 4 minutes left, maybe you can both respond with comprehensive answers. And Dr. Trust as well, you can also do that. And just to say, if maybe you had put a scenario of a 50-year-old there, we would have appreciated menopause to be included, because we're really feeling hot in here. All right, Dr. Helen.
I agree. I just want to pick up your point of drug interactions, but what about the pill burden these people are facing? We had diabetes, we had hypertension, we had X, Y, Z, with the challenge for adherence as well as we manage these comorbidities. I think we have to recognize that. We're talking about fixed dose combinations for hypertension now. Maybe there's fixed dose combinations for diabetes. Are there those programmatic elements that could simplify that pill burden as well? I'll try to respond. I'm not sure I completely got the question around the adolescents, but what I would say is, we need to be aware of prevention of non-communicable diseases as well as we're aware of prevention of HIV. Yeah, we should be promoting healthy lifestyle, exercise, healthy diet. It's as much. I really think it's going to be, or is now, you know, potentially as important as the work we do around preventing HIV, because certainly I've been looking at some of the obesity data, and we see there's a real transition in terms of rates of obesity across the continent. And this is really worrying. You know, going with that will be worse diabetes, worse hypertension, etc., worse osteoarthritis, you know, worse joint musculoskeletal problems. So I think we need to think about health education around diet, exercise, if we want our adolescents now to age healthily.
Thank you. Just in addition to what she has said, the best time to teach healthy aging is before people age. Some of us is too late. We've already aged. So all I'm just saying is for the adolescents, let's intervene early. On top of what she has said, the thing that came to my mind as well is HPV vaccination, because cervical cancer is a common issue in our setting. So yeah, healthy aging, lifestyles, exercise, and all that. Over to you.
Thank you very much. Very fascinating discussions. Like I said, the biology of aging in HIV and inflammaging talk would have been a very interesting one at this forum. But for me, it's just a plea to the basic scientists looking at aging itself, because aging is actually a process which starts at conception. It's not some, you have to wait for some age to just say, well, now you're aging. So at the point of conception, when you're born, you're already aging, and that's important. And I think HIV itself, one board round in Perinatal Hospital, we saw a 55-year-old man. And I said to the medical students, how old is this man? And they all said he's 75. And you start looking at your HIV patient in front of you and trying to estimate their age. Medical students are giving us 10, 20 years above for some of the patients we are seeing. So it's really a real issue. So my point is, from a research point of view, much as we have a lot of public health work that goes on, we need to appeal as well to the basic scientists in terms of targeting aging in an HIV patient. There's a lot of work